Oh, where's my face?
All righty. Good morning, everybody, or afternoon, I guess, everybody. We'll be getting Kelly on, our marketing director, just to kind of go through some of the basic logistics of the meeting today. I'm sure people will be kind of coming in and out sometimes, especially with the webinars, they tend to do that. So try to make sure that you're always muted, and your video may be on or off. That's okay. That's at your discretion. But just remember that this is getting recorded, and we're going to be posting this online afterwards. So just try to be mindful if you have your video on, maybe don't head over to the bathroom or something, and make sure that you're muted, as that might be a little bit embarrassing. So we'll hopefully, Kelly, let's see, Kelly, where are you at here? There you go. So Kelly, are you on?
I'm on. Can you hear me?
Yes, I can hear you.
Can you see me? I don't think
Yes,
you can
I can see it.
Oh, hi. So great. I didn't know you could see me.
Yes.
Wonderful. Hi, everyone. I'm Kelly. I'm sorry for logging in late. I just want to introduce Dr. Nick Callahan. He probably already did that while I was logging in, but he's here to talk about the anterior minimally invasive hip replacement surgery and the Bikini incision. Please mute yourself. You should all be muted, but stay muted, please. And when you have questions at the bottom, at the end of his presentation, hit the chat feature at the bottom of your screen and we can get your questions answered for you. So this will be posted on his website, probably within the next 24 hours. And that's really it. So Dr. Callahan, if you'd like to take it away.
Sure.
I'll mute myself. Okay.
All righty. So let me get this started on sharing my screen. And we'll pull that up. Okay. So let's get this into our presentation mode. All right. So thanks, Kelly, for the introduction. And I know people will be coming in and off, like we said before. That's okay. Just try to make sure you're muted. Like as Kelly had said, we'll post this on our website, hopefully within the next 24 hours, available to you. So feel free to write down anything that you see in there, and maybe you can go back and find it different parts of the video. And then, of course, if there's any other further questions, you can send an email through our website, or see me in office for a personal consultation. So hello, I'm Nicholas Callahan. I'm an orthopedic surgeon, joint hip and knee replacement specialist, that I'm here to talk to you today specifically about my anterior minimally invasive hip replacement techniques, and specifically using a bikini skin incision as well. The first thing is I have no disclosures relevant to this topic. Also, I'd like to start off with a disclaimer as well that this is a general overview. This is not a time for individual consultations. There are some privacy issues, obviously, that go into asking personalized questions. So please remember to, during the question and answer session, to refrain from asking those personal questions. I would be absolutely happy to answer those questions for you, but the best time to do that is in an individual consultation in my office. That way we can address it more specifically and in a private manner. So we'd be happy to have you schedule an appointment with me. Down below in the slides, I kept the number available, and you can also look on our website as well. It's available, or Google search us. So first we'll talk a little bit about some recent patient of mine that was having some maybe similar complaints or symptoms, or someone you know or family or loved one that you know might be sharing the same symptoms. She came in to see me, 68-year-old female, was having right hip pain. It was making it really difficult to do the things that she loved. She started to notice that she was avoiding her activities, spending time with families, couldn't travel the same, or if she did, she was having difficulty with it, having difficulty sleeping. She started to having difficulty even recognizing herself, and people were like, yeah, you're really grouchy lately. You're, kind of having all these kind of grumpy, and didn't realize how much this was affecting the quality of her life. And she came in for a consultation. We got the x-rays you see on the left. and shows really bad arthritis of the hip, and particularly the right hip. And we talked about how she wants to get back into living her life again. So we'll go over why anterior minimally invasive surgery is a great way to accomplish that. So today we're going to go over some basic hip anatomy. We're going to talk about what's arthritis, how is a minimally invasive hip replacement done, and why are we even mentioning bikini skin incisions. So a quote I like to always share from Sir Isaac Newton is, "If I have seen further, it is by standing on the shoulders of the giants that came before me." And so the reason I mention this, because I like to always recognize where I came from. And Ryan Molly and Phil Frendak were my trainers, where I learned these techniques from. And in addition to providing me excellent training and surgical skills and advanced hip and knee replacement techniques, they really showed me how to be a great physician and person. So I like to give them special thanks every time I talk to anybody about these techniques. Personally, I'm from Amherst, Ohio, so I'm a Northern Ohio born and raised person. Yes, it does make me sometimes, unfortunately, a Browns fan. I do like the Guardians and the Cavs as well, which are a little bit more of our bright spots, but hopefully we can turn the thing around next year with the Browns. We're always perpetually hopeful. I went to college at Baldwin Wallace University. It's in Berea. And Lake Erie College Osteopathic Medicine for my medical school, as well as my orthopedic surgery training. I then did a whole year of advanced training in specific hip and knee replacement techniques with an emphasis on minimal invasion type techniques at the Whole Health Joint Replacement Institute in Meadville, Pennsylvania. So why do I do this? Well, first off, I love it. I enjoy this very thoroughly. The whole point I went into medical school and training was to learn how to help people. And I still think that's a really important part of my practice. And why I love doing these techniques is because I get to do that, and I get to see the changes in people, and I see their faces brighter when I walk in, or when I see them after surgery and they're following up. I can see the change in their face, and that just gives me such satisfaction. So we're going to next talk about going back to school and review some basic hip anatomy. So there's two main bones that form your hip joint: the thigh bone, or your femur bone, which contains the ball portion of the ball and socket joint, and your pelvis bone, which is that contains the socket side. So these two bones meet and form your hip joint. Specifically, when you talk about arthritis of the hip, it involves this area where these two bones meet. The surfaces have cartilage on them, and they allow for a friction-free joint. So they can move around, and that substance is very slippery and smooth and allows it to move around without having any pain. So what's arthritis? Well, that substance that we talked about, every joint has some level of cartilage on the surface of the joint, and that allows for pain-free motion. And the reason that you don't have any pain is because there's no nerve fibers that are in that normal cartilage. Over time, arthritis happens from several different types, but in some way that it happens, it wears away this cartilage and the bone starts becoming exposed. And when that happens, the bone develops bone spurs. It becomes harder, rougher, and frayed. Some of the cartilage might be partially lost or fully lost. And when that happens, that can catch, and it can give you a zinger. Like if you get a certain way, or sit a certain position, or turn your leg a certain way, it can touch those bones together, and it's very, very painful. And the reason is because your bone has a lot of nerve endings in it. And when it gets irritated, boy, do you know it. So arthritis, when we have that type of symptoms of pain and swelling and stiffness, we get an x-ray of a joint space to evaluate whether it has that and what the extent it's involved with the joint. So the x-rays that you're looking at on the left aspect of your screen show a normal joint, so the ball and socket joint of the femur, with good joint space. There's a smooth round ball. There's no real significant amount of white. It's pretty uniform throughout its appearance on the x-ray. So the space is good. You don't see any kind of bone spurs. That's a healthy joint. You look over to the right picture, there you can clearly see that joint space is gone. So there's no more of that black space, which means the cartilage has worn away. And then there's a lot of white in that area. It's very intense white. And that's showing you that bone is hardening, because as you rub bones together, they have to get harder or they start to crumble apart. So they become harder, and then that's like rubbing something really rough against each other, which can be very painful. And while that's happening, the joint space tries to increase its size by making these bone spurs to spread out the pressure across it. And so you can see that on an X-ray, and that's what indicates arthritis in a hip joint. So how does it happen? Well, the most common is wear and tear disease, so that cartilage starts to soften and break apart. That specific mechanism is not yet understood by us in science, but we do know that there's some other things that can happen that cause arthritis, like if you've had an injury to your joint or had a fracture previously in a joint, that can cause arthritis, that cause that cartilage to wear away. Or if you have a specific condition that causes inflammation into those joints, like rheumatoid arthritis, gout, pseudo-gout, or several other different types of medical conditions that cause arthritis, can cause that cartilage to wear. At the end stage, you do end up having symptoms regardless of the reason it's coming. We do have those symptoms that are very consistent, which is pain, stiffness, swelling, maybe some motion changes, so you can't get around as well as you used to, along with some of those things we talked about earlier in our case example, which is maybe you're having some avoiding certain activities you like to do, or you might just start to notice you can't exercise as much or stay physically active. And that tends to make people gain a little bit of weight and may make you depressed. You may lose sleep over it, might be aching at nighttime or stiff in the morning. These are very, very common complaints of arthritis. So what do we do when we get arthritis? How do we treat it? Well, beginning stages or earlier parts, there are options regarding arthritis treatment. That includes medications, over-the-counter or prescriptions, including Tylenol or anti-inflammatories. There's also injections that can be done. Sometimes the pain is not actually coming from the hip joint. It could be coming from outside the actual ball and socket joint. And those could be bursitis, or it could be even a nerve issue, a pinching nerve in the back. So sometimes we have pain over the area and it's not quite coming from the hip joint. But there also are injections that can be done into the hip joint itself, like a steroid injection, that can help to manage those symptoms of arthritis. Physical therapy and exercise is always important to help improve our quality of life and keep us moving. Motion is good for joints, but pounding exercise is generally to be avoided. So any kind of significant running activities, those can be harmful to the joint. Although if it does produce a lot of quality of your life and you enjoy running, it's something that you've been doing, you can continue doing those types of activities. The important thing is to maintain your active lifestyle. And then when it gets particularly difficult, there are some assisted devices like canes or walkers that can use to help share a little bit of the weight or shift it over. At that point, you need to start maybe considering the consultation to talk about, hey, maybe we could do better than that. Maybe there's something that's going on that's a little further to investigate what our next steps are. So what happens when you've tried all these things and you still can't get the relief, or you have been doing these things and having good relief and you start getting diminished returns? So you've had injection, it's not working as well anymore. You start to notice that, maybe the things that you were doing, you can't do as well. Well, that's when we start talking about surgery. And so specifically for ball and socket joint arthritis, total hip replacement, or arthroplasty formally, is removing that worn bone and cartilage and replacing that with a metal and plastic implant. So when we do this, we remove that worn bone and cartilage on the socket side and place a metal cup inside of the pelvis bone, and we make a opening in the femur, which is cutting off the bottom part underneath the ball part of the ball and socket joint, and placing a metal stem into the femur bone. And then we place a metal or ceramic type of ball and a plastic liner within that metal cup, and that forms a new hip joint. The hip joint is held together by the forces, the very, very strong muscles around your hip joint hold that ball and socket together. So are all hip replacements the same? Well, obviously we're here talking about this, so clearly they are not. There are different techniques to replace a hip. All at the end stage, total hip replacement, the end products are very, very similar as far as what you have. You have a socket, you have the ball, and you have the stem that attaches the ball in that plastic liner. But how you get there is different. So there are three major approaches to the hip to replace a hip. There are tons of names, and you may have heard of some of these names. They seem to kind of rebrand these names over time. But the three techniques have been described for decades and have been used for decades to replace hips. Despite what we talk about how you do it, it's just kind of three major ways to approach the hip. And so that's anterior minimally invasive hip replacement, or also called a direct anterior hip replacement. There is classically the posterior or posterior lateral, a sexy new name for that approach, and a slight modification of that technique is called the direct quote superior technique, and a lateral or antilateral approach to the hip. And we'll go through that here in a second. So with my joint replacement technique, I use an anterior minimally invasive hip replacement, which is what we're here to say and talk about. And the reason that's important is I don't cut any of the muscles. And so when you look at the hip joint itself, it faces forward. The ball and socket face in a forward direction. So in this diagram, the front is at the top, the back or your backside is on the bottom part of this image. You can see there's like a skin layer, and then there's a little fat layer, and then there's the muscles. And those gluteus maximus muscles, medius muscles, those are from the backside of your femur and go around and wrap and attach to the femur. And then there's the muscles that come around the side and into the front of the hip. So if the hip joint, the ball and socket, face forward, why wouldn't you go from the front to replace that? And so this actually has been a technique that has been used in the past, and the first described in earlier techniques of doing hip replacement surgery from the front is back into the 1960s. So what we do is we go through this area that's around these muscles, and this dark blue or purple line, depending on your computer screen, this dark purple line kind of shows how we do this. We go around the muscle that's in the front of the hip, and in between these, and there's a natural plane that goes all the way down without having to cut or disturb these muscles, okay? And we get down to the hip joint, and then the procedure at that point is to remove the worn ball and socket and replace it with the metal socket and stem and plastic liner, okay? So classically, that is not the way that is done. And there is a large number of surgeons who use approaches that are from the side or the back. And so the difference being is, as you see this dark blue or purple line from the front, that's the technique that I'm using to get down to the hip without cutting those muscles. This would be more approached from the back. So going right through this big gluteus maximus muscle, and then these little rotator muscles that are behind on the back portion of the femur. And then what you do is you cut through all those muscles, and then you dislocate the hip or pop it out from the back. And then if you want to do the lateral approach, you actually go through this muscle here in some way, shape, or form, this gluteus medius muscle, which is a muscle belly that helps you kind of put your hip out or swing your hip out to the side. And in order to get to the hip joint, you have to go through there, and then it pops out from the front through that muscle interval that you cut through, as opposed to going through this natural plane here. And so why does this even matter? Why am I going through all this point of making this statement? Well, who cares if you just cut those muscles? When you do the surgery from the back or the side, once you've cut those muscles, you can open up that hip joint and you can do pretty much whatever you want to do with there. And if you need to do more, or you need to see more, you just cut open more muscle and you can do that. But why would that matter? Well, as you can imagine, it's painful if you do that. So when you cut muscle, that's painful, and it has to recover and heal. Well, muscle does not heal with muscle tissue. There's only two types of organs or tissues in your body that heal with the exact same tissue as it heals. That's bone. When you break bone, it heals with bone. And the liver has the ability to regenerate itself and heal with its own tissue. Other than that, if you cut the tissue in your body or do something with your body, it doesn't regenerate with that substance. So it forms scar tissue in that area. And so muscle doesn't regenerate new muscle once you cut it. It regenerates with scar tissue. And when you cut those muscles, it tends to cause it to fill in that space with fatty fibrous tissue. And what this MRI shows on the right here, there's a left picture using a conventional approach to the hip. This shows that there's this kind of darker area, which is the normal muscle tissue, and there's a lot of white and stranding within that tissue. That's that fatty fibrous tissue that develops. When you use techniques like the technique I use, the minimally invasive technique, you can see all this good muscle tissue. So this is a very, almost the exact same level of tissue comparing side to side. And you can see how much more red that there's in there, darker tissue that's within this space. That's preserved muscle because we didn't cut that. So why does that matter? Well, your recovery tends to be faster in the first 6 to 8 weeks after the surgery when you don't cut those muscles. You don't have to worry about these dislocation precautions that you have to worry about when you go through the back. So if you cut through muscle, that tissue is now disturbed, especially when you come from the back. That tissue is disturbed. It has to heal in order for it to keep it in the position it needs to be. Because remember what I told you is that when you do a hip replacement, the thing that keeps the thing together, the ball and socket joint, this artificial joint, is all your muscle forces. Well, if you cut those muscles, then you have to allow them to heal and go through a healing period before you can say confidently, hey, that's going to stay in the place it needs to be. So that's why you've maybe heard of hip replacement patients who have to use a raised toilet seat or a special grasp, or have to avoid for the first 6 to 8 weeks, that they have to allow that tissue to heal. So they have to don't tie their shoes or cross their legs or put a pillow between their knees while they're sleeping, so they can avoid for that hip popping out. This technique, we don't need to be concerned about that because I don't disturb that area of your body or those natural muscle barriers. Those are maintained, so we don't have to worry about those types of things. So it's a real important distinction point to mention that over time, every hip replacement can be done well. And if it's done appropriately, you can recover and heal well and have good quality of life and outcomes. However, doing techniques with minimally invasive, especially this anterior approach, allows you to recover faster and get back to doing things you love. In the first 6 weeks is when it's really critical for that. And it allows us to do those things better and faster. So why are we talking about bikinis? What does that have to do with anything? Well, one of the things in my main philosophies, as we'll even talk about later, is I like to respect the anatomy. So if I'm respecting the anatomy and taking good, painstaking efforts to preserve the anatomy of the musculature of the hip and using this natural interval to the front of the hip to do the replacement, then why wouldn't I also apply that to the skin when I'm going down to get to that muscle interval? So when you do a standard hip replacement from the front, a long way incision is how you do it. And so this is showing somebody that they're standing forward facing you. Their head is towards the top of the slides. Their feet would be to the bottom of the slide. And then towards the middle of their groin is to the left. And then to the outside part of their hip is to the right. You can see there's a long way incision. So this is a well-healed incision that's going down the front in a long way fashion. And it's a very tried and true way of doing it, and it's appropriate, and that's a well-healed incision for the anterior hip. Well, when we start to look at the way that the skin lies down in the front of the hip, it has more of an oblique or a diagonal type or sideways horizontal configuration, the way the skin lays down. And so what that means is the grain of the skin lays down in a way that's more not straight down. So if you cut against the grain of the skin, it tends to leave a scar that's a little less appealing. While that's important and we care about preserving the cosmetic appearance of the skin, it also makes it, when you cut against the grain of skin, take a little longer to heal or have a little more effort. And so in somebody who may have a little difficulty healing wounds, that can present a problem, and is an area that when you go to the front of the skin, the front of the hip to do surgery, the skin is a little bit thinner than your backside. And so that can present issues with that wound healing. But when we respect the skin lines and the natural grain of the skin, it tends to leave a more cosmetic appearance of the skin and allow for better healing environment so that the wound has less complications. And again, we can see here, this is a patient about 6 weeks post-op of a left hip, and that same type of incision as far as in the front of the hip, but we respect that skin line. You can see just about there. That's where that incision is. And then at 6 months post-op, I mean, there you can barely tell that between the natural lines of the skin that's where that skin incision is. And so going back to our patient, previously we talked about after having gone through all of our conservative measures and treatments, going forward with an anterior hip replacement with minimally invasive techniques and using a bikini skin incision. And she did elect to go through with this. The pictures on the right are showing the total hip replacement done with this approach. And after seeing her at 3 weeks, she was already feeling much better and much more pleased with her ability to get around. 6 weeks after her surgery, she was doing fabulous, able to get back to doing a lot of things she loved to do, and is now traveling all over the place and zipping around and enjoying her life, and able to get back to, again, what we love, which is why I like to do that. So overall, my joint replacement techniques, the philosophy is to respect that anatomy, use those minimally invasive techniques. And with this, and the advent of this, I've been able to have a lot of my patients go home the same day. So using outpatient joint replacement, which is that you could sleep in your own bed. Now this is when medically appropriate, of course, but because of these techniques, we've been allowed to, or I've been able to send people home a lot more frequently the same day of surgery. And overall, my mission, as always, is to provide excellent care. I want to improve my patients' quality of life, and I want you to get back to doing the things you love. Those techniques that I use beyond my anterior minimally invasive hip replacement surgery and bikini skin incision with that is a partial knee replacement and kinematic total knee replacement. I have a webinar on my website if you wish to, that's already been published that we did regarding kinematic total knee replacement. And we have a forthcoming partial knee replacement webinar that we'll be planning around March time. So stay tuned to that. We'll publish that and send it through the emails and on our website soon. If you'd like to set up an appointment, please give us a call. The number's at the bottom of the screen, and our location is at Beechwood Medical Center. And I'm happy to see you and talk to you about everything. And hopefully we can answer any of your questions that you have here. Kelly, were there any questions within our chat function?
I don't see any questions in the chat. No, I mean, I feel like it was very thorough.
Okay. Well,
so yeah.
One thing I would say is just to give people a little more time in case they were thinking about it or have any questions. There's some common things I usually hear about when they ask questions regarding hip replacement surgery, recovery, that kind of thing. So hip replacement surgery in general, the recovery time frame is somewhere around 12 weeks as the big part of the recovery. With these techniques, it's a lot faster. It tends about I'd say probably around 3 to 6 weeks for the big part of the recovery. Most people are able to, after the skin is healed from the front of the skin, they're able to go back to doing a lot of the things that they wish to do early on. Heavy lifting and weight bearing activities like lifting weights and things. We usually wait about 12 weeks before going into that, as the implants have to grow into the bone has to grow into the implants that we use. So we like to kind of hold off from those kind of extreme activities. But I'd say is that the overall thing with my hips, especially since using these techniques, is that we got to kind of slow people down rather than speed them up. I think I see some questions popping in here on our chat.
Yes, we have a question. Do they wear out after do the hip replacements wear out after 10 or 15 years, and are they easily replaced?
Great question. So the hip replacement, in the past, they used to talk about a rough estimate of time was around 15 to 20 years of a hip replacement lasting. That's because there's that plastic part that's in between the ball and socket part. So there's metal stem, the metal socket, usually a ceramic or a metal ball, and then a plastic is the most common surfaces that we put into a hip. Okay. That plastic part was the part that would usually wear out over time, because as you bend and straighten the hip, that ball and socket is kind of wearing away that plastic. With the older plastics, that's what we were projecting. Now the newer plastic that we've learned how to and discovered how to change that plastic and make it last longer. They're projecting much longer lives with these. And when they study this, when they look at the hip replacements that are being done with the modern plastics, they're projecting to last much, much longer than that. Now, can we say honestly, or anybody look you in the face and say, you specifically, your hip replacement will last for 30 plus years? No, we have data in labs that simulate this. But we, of course, if we just, within the last 10 years or so, have this plastic that's been, improved upon, we don't have 30-year data yet to show that, with a study. We can just only project to that. So the goal is for it to last you for your whole life. If it is something where the plastic starts to wear out, it's important to maintain follow-up with people, because if we see it wearing out a little early, there is an ability to potentially change the plastic and the ball part out and maintain the other metal parts. And that's a much easier procedure to undergo. But again, that's very specific, and there are other reasons that hips can wear out for other problems that may not be applicable to that. So hopefully that answered that question.
Great. There's one other question from Susan. It says, my friend had a hip replacement. It was anterior, but the incision was up and down. Does that mean it wasn't as aesthetically pleasing, but still minimally invasive?
Great question. So so over the advent of time, and something to maybe touch point on, is the bikini skin incision is a relatively newer technique that's being adopted. When I first started doing them, I did everybody with a long way incision or a longitudinal incision, which is that up and down, straight up and down incision. And people did fabulous. It's not to say that you can't have an excellent outcome and it's not minimally invasive to do it. I think that's just that technique with the bikini skin incision is the next level, like to get to that. And it's something that improves the appearance of it and the wound healing, especially in certain patients that have difficulty with healing wounds. This is taking it to another level. But of course, doing an incision long ways can do very well. The techniques are minimally invasive under the skin. I just think that's the next level, natural progression of making it more anatomically friendly.
Okay, there's one other question. Will there be PT required post-surgery? Hang on. And can one come from west side of Cleveland, have the surgery and do the PT if required at a west side facility? So it's a PT question there. Oh yeah, so it certainly depends, I guess, on the specific your specific circumstance. We can talk that in a more formal consultation. But generally speaking, I do have my patients undergo physical therapy after surgery. I think it's important to have touch points with physical therapy and making sure that they're meeting with you. I do use a program called PT Genie, which is an electronic monitoring as well with your mobile phone, and you can kind of track along and keep progress with you. So we're pretty flexible in the ways you can accomplish the therapy. But then, and if there's a specific physical therapy group you've worked with in the past, I'm willing to work with you about that. It just depends, where you're talking about, but we can work with that and adjust. I have a therapy protocol that I use for my patients for the hip replacements that I like to have them to complete. And so we can send that protocol or work with you on that specifically. Okay, and there's one more very, very general question, not really specific to what this approach, but I guess if you had to make a generalization, how would you compare a new hip to a 20-year-old hip for mobility? And I don't know if she means 20-year-old hip that's been replaced or just in general, but. Okay, so I think then, so that if I understand the question correctly, that comparing to one that was done 20 years ago, it almost sounds like. Yeah, I think that's now. So it kind of gets back to a great point that we were trying to make earlier, which is a hip replacement can be done and have great success, and they have been done with great success
very high satisfaction rates with hip replacement surgery for a very long time. But over the course of time, we have continued to tinker and improve this approach and these techniques. And people have had better and better outcomes. So in my view and mind, I believe that we are doing better than we ever have on a hip replacement. So if you have a hip replacement done now, I think it's certainly with our techniques and our protocols and our care pathways, we have really improved the overall experience of a hip replacement. So I think in that way, we have certainly really moved way further along than 20 years ago. And that's very clear because 20 years ago, the concept of even understanding and recognizing the problems that we have with opiates in this country was not as evident. And that's a many issue problem. Like, so there's a lot of factors that go into that and why that was a problem. And it's not just hip replacements. It was the whole country, it was the whole medical profession, et cetera, that was having difficulty. But we've definitely changed and improved that, where we have to use a lot less of that. And we use a lot of other aspects and techniques, and we take into consideration more of a holistic approach to patient care across the board. And certainly that's my approach. So hopefully that answered that question.
Yes, I think it did. One more, I think, here from Earl. I've had both hips replaced 35 years ago and 3 replacements over the years. I can only say it has been life-changing. I walk, bike, ride, and are lucky to be very active. I highly recommend doing it, and thank you for making a difference. So that was a nice comment.
That's very sweet. Yeah, definitely. Well, I think that's a great testimonial of that. You have a hip replacement. I think one thing that I would say to piggyback that, and thank you for making that comment, is that one thing I get very frequently is the question, and we have actually a lecture on this as well, that is about, when do I go ahead with a hip replacement? Well, ultimately, to give you the quick explanation of that, or the cliff notes, is that you're the one that decides that circumstance. It's a personal decision. I'm there to help you make that decision. And I never force or tell anybody, oh my gosh, you have to have a hip replacement for arthritis. We talk together and we figure out a plan that makes the most sense for you, including your medical circumstances, your social circumstances, where you're at in your life, and your and work circumstances. But I'll tell you, the most common thing I hear after we get to the point where we get to do the hip replacement is, boy, I wish I would have done this sooner. After you figure out how much relief you get and you get through that, people are so much, happier with where they're at. And that's why I think it's important to maybe, survey other people in your family and talk to them like, hey, sometimes they have a little better insight than we even do in ourselves about that, and are able to say, hey, you've been kind of grouchy lately, or you're not doing the things you used to do or what you love to do anymore. Maybe it's time to think about that.
Okay, great. Well, that was very informative. Some great questions at the end. I hope to get this recording live within the next day, and you know what, I'll email it out to everyone so they have it. And of course, obviously, if you're not here, you missed it, but the people that weren't able to join us today will receive it via email. And thank you, Dr. Callahan. I thought that was very, very well done.
Thank you, Kelly. And just again, anybody that, if you didn't get your question answered, I absolutely love answering questions and making sure we make the best circumstances for you. So just go ahead and write it down. And I'm happy to spend time with you talking about it. If you want to, come in for the consultation, just like, hey, I saw your webinar. I just wanted to get these questions answered, and I would love to do that. So thank you so much for taking the time to spend time with us this afternoon. I hope you're all staying safe and well, and look forward to seeing you soon.
Thanks.